Good evening, everyone. So, my next video, which I'm going to discuss with you, is on parental anticoagulants. Now, what are the parental anticoagulants? This I will discuss with you in this video. And before I start this video, I want to request you, if you like this video and if it is helpful to you, kindly subscribe to my YouTube channel, that is Dr. Nitika Pharmacology Discussion. And now I'm going to start with you on the topic parental anticoagulants. So, what is the anticoagulant? It is the drug which prevents the clotting or coagulation of the blood. Anticoagulant is a drug which prevents the coagulation or clotting of the blood. And these drugs tend to prevent new clots from forming or an existing clot from enlarging. Means they prevent the new clots from forming or the existing clot from enlarging, and they do not dissolve in blood clot. These drugs they do not dissolve in the blood clot. The classification of parental anticoagulants are indirect thrombin inhibitors are heparin, lower molecular weight heparins, fondaparinux, and tenofovir. Direct thrombin inhibitors, which inhibit the factor 2A directly, these are lepidolin, bivalirudin, and ergotapan. So now, what is heparin? Heparin McLean, a medical student, discovered in 1916 that liver contains a powerful anticoagulant. Now, medical student, he discovered in 1916 that liver it contains a powerful anticoagulant, and Howard and Holt in 1918 named it heparin because it was obtained from liver. Heparin is a non-uniform mixture of the straight-chain mucopolysaccharides. Means it is the mixture of straight-chain mucopolysaccharides with molecular weight 10,000 to 20,000, and it contains polymers of two sulfated disaccharide units such as D-glucosamine and L-iduronic acid and D-glucosamine and D-glucuronic acid. It carries strong negative electronegative charges. It carries strong electronegative charges and is the strongest organic acid present in the body. And this is the strongest organic acid present in the body. Heparin is found in the secretory granules of mast cells. Hence, heparin is present in all the tissues containing mast cells. Means it is present in the secretory granules of the mast cells. And so, it is present in all the tissues which contain the mast cells. And its richest sources are lungs, liver, and intestinal mucosa. Commercially, it is obtained from ox lung and pig intestinal mucosa. It can be obtained from commercially from ox lung and pig intestinal mucosa. So heparin is a powerful and instantaneously acting anticoagulant. Means it acts instantaneously. Means it has a rapid onset of action, and it is effective in both in vivo. In vivo means in the human beings, and in vitro means in the tissues of animals. It can be effective, and it acts indirectly by activating plasma antithrombin 3. This heparin, it will attach to the antithrombin 3, which is the serine proteinase inhibitor. And this heparin antithrombin 3 complex then binds to clotting factors of intrinsic and common pathway and inactivates them. Means heparin will complex with the antithrombin 3, and it will inhibit the factor 10A and factor 2A, which are the parts of intrinsic and common pathway clotting factors, and they will inactivate these closing factors. Which clotting factors? Factor 2A and factor 10A. It is exerted by mainly by inhibition of factor 10A and 2A mediated conversion of fibrinogen to fibrin. Means 10A and 2A will be inhibited, so there will be no conversion of the fibrinogen to fibrin. No action on factor 7A operative on extrinsic pathway. Means it has no action on factor 7A, which is operative on extrinsic pathway. It is only present, its action is only present in the intrinsic and common pathway clotting factors. Low concentration of heparin prolong the activated partial thromboplastin time without significant action on prothrombin time. Means it will prolong the activated partial thromboplastin time, but it will have no action on the prothrombin time, whereas high concentration prolong both. And higher concentrations will prolong both the prothrombin time as well as activated partial thromboplastin time. And low concentrations, it will prolong only activated partial thromboplastin time. So this is the coagulation pathway. This is the and this heparin, it will combine with the antithrombin 3 and it will inhibit the factor 10A, factor 2A, factor 9A, factor 11A, factor 12A. And this factor 2A, which is activated, it will convert the fibrinogen to fibrin. So this factor is inactivated. So there will be no conversion of the fibrinogen to fibrin. Heparin enhances the action of antithrombin 3 in two ways. How it enhances the action of the antithrombin 3? It's by holding for the clotting factors 10A and 2A mainly, and antithrombin 3 to get bound and interact with each other. Means it will bound and it will antithrombin 3, it will bound to the antithrombin 3, and these clotting factors like factor 10A and 2A mainly will be inhibited. Induces conformational changes in the antithrombin 3 to expose its interactive sites, and will induce the conformational changes in the antithrombin 3 to expose its interactive sites to factor 10A and factor 2A. Inhibition of 2A factor requires both mechanisms, but factor 10 inhibition can occur by second mechanism or more. Means 2A inhibition can it requires both the mechanisms, that is scaffolding for the clotting factors also, and a conformational changes in the antithrombin 3 also. But factor 10A can occur by second mechanism only. Means we just induce changes in the antithrombin 3 and there is exposure of its sites. That is why lower molecular weight happens, which can which can't provide scaffolding, selectively inhibits factor 10A. Because that's why lower molecular weight happens. They will only induce the conformational changes in the antithrombin 3. So they will only inhibit the factor 10A and they will not inhibit the factor 2A. So this is the diagram to show. See, this is the unfractionated heparin. It will complex with antithrombin 3, and antithrombin 3 complex and heparin complex will inactivate the factor 10A also, and thrombin, which is 2A, will also be inactivated. Lower molecular weight heparin will combine with antithrombin 3, and it will only inactivate the factor 10A because it is small in structure, so it will only inhibit the factor 10. Actions, it has the antiplatelet action, heparin high doses, inhibits the platelet aggregation and prolongs the bleeding time. Lipemic clearing. This injection of heparin clears turbid postprandial lipemic cell plasma by releasing a lipoprotein lipase. It releases the lipoprotein lipase from the vessel wall and tissues, and thus it hydrolyzes the triglycerides and VLDL to free fatty acids. Thus, they pass into tissues and then these then pass into tissues and the plasma looks clear. Means in the fatty tissues or in the vessel wall, the lipoprotein lipase will be activated or it will be released by the heparin, and this will convert or it will hydrolyze the triglycerides and VLDL to free fatty acids. And then these then pass into the tissues and then plasma remains clear. Pharmacokinetics, it is the large, highly ionized molecule not absorbed orally. It is highly ionized molecule and it is not absorbed orally. We have to only give it parenterally. Do not cross blood-brain barrier or placenta. It is metabolized in liver by heparinase and fragments are excreted in the urine. This will be metabolized in the liver by heparinase and the fragments, they are excreted in the urine. Heparin released from mast cells is degraded by tissue macrophages. Means the heparin which is released from mast cells, it is degraded by the tissue macrophages. And bolus of 5,000 to 10,000 unit IV followed by continuous infusion of 750 to 1,000 unit per hour or 10,000 to 20,000 unit 8 to 12 hours is the dose. So next is monitoring heparin. We can monitor heparin by the activated partial thromboplastin time, which is prolonged. Normal range is 20 to 40 seconds. Therapeutic range is when the heparin is given, its range is 50 to 70 seconds. Adverse effects, it causes the bleeding due to overdose. It's the most serious complication of heparin therapy. Now, it can produce bleeding because due to overdose. And hematuria is commonly seen, which is generally the first sign. That is, blood in urine will appear, and it will cause bleeding because in overdose it produces anticoagulation. So that will lead to bleeding. Thrombocytopenia is common but mild. Uh, Thrombocytopenia, that is decrease in platelet counts, can occur. Occasionally serious as a result of antibodies against heparin platelet complex. Now, thrombocytopenia is occasionally serious as a result of antibodies against heparin platelet complex and marked depletion of platelets occurs. So, it is marked depletion. There will be formation of heparin platelet complex, and then there will be depletion of the platelets, and that will lead to heparin-induced thrombocytopenia. Transient and reversible alopecia can occur. This is loss of hair. Osteoporosis may develop during long-term use, and hypersensitivity reactions are rare. Contraindication is this is contraindicated in bleeding disorders, heparin-induced thrombocytopenia, severe hypertension, threatened abortion, piles, and GI ulcers. As it causes bleeding, so it will be contraindicated in the threatened abortion, piles, and GI ulcers, subacute bacterial endocarditis, large malignancies, and tuberculosis. Chronic alcoholic cirrhosis, renal failure is the contraindication. Aspirin and other antiplatelet drugs should be used cautiously during heparin therapy. Now, next is lower molecular weight heparin. Heparin fractionated into the lower molecular weight forms the molecular weight 3000 to 7000 by different techniques, and selectively it inhibits only factor 10A, active inducing the conformational change in antithrombin 3. Less effect on activated partial thromboplastin time and whole blood CT then, that is whole blood clotting time, then the unfractionated heparin. This has less effect on the clotting time and activated partial thromboplastin time. Eliminated by kidneys can't be used in renal failure. As it is eliminated by kidneys, so it can't be used in the renal failure. Now, what is the mechanism of action is any size of heparin chain can inhibit the action of the factor 10A by binding to antithrombin 3. And in contrast, in order to inactivate thrombin 2, the heparin molecule must be long enough to bind both antithrombin and thrombin. Means the heparin molecule should be large enough that it binds the antithrombin also and thrombin also. But low molecular weight heparins, they have a low size, so they will inhibit only tech factor 10A by inducing the conformational changes in the antithrombin 3. Now, this is the differential inhibitory activity against factor 10A and 2A. Unfractionated heparin, it will inhibit the thrombin also and it will inhibit the factor 10A also. By binding to antithrombin, most unfractionated and lower molecular weight heparin can inhibit the factor 10A. Because they can inhibit the factor 10A activity. Fewer than half the chains of lower molecular weight heparin are of sufficient length to also bind to factor 2A or thrombin, therefore has decreased anti-factor 2A activity. Because the chain is just fewer than half of the chains of low molecular weight heparin. So they will only bind to the factor 10A and factor 2 is not affected. Advantages of low molecular weight heparins over unfractionated heparins, they have less interference with platelet function. They will cause less thrombocytopenia and they will also have less hemorrhagic complications. They have a better subcutaneous bioavailability, longer and more consistent half-life. OD dose means they can be given OD because they have a more consistent and longer half-life. So once daily dose can be given. And there is no prolongation of activated partial thromboplastin time and clotting time. Lab monitoring is not needed because there is no prolongation, so we cannot, lab monitoring cannot be done. Nearly equal efficacy to unfractionated heparins and less incidence of the heparin-induced thrombocytopenia, less interaction with platelet factor 4, fewer heparin-dependent IgG antibodies. So now molecular monitoring of the lower molecular weight heparins, it is unnecessary in majority of the cases and may be used in special instances like renal insufficiency, in bleeding risk factors, and in obesity. Activated partial thromboplastin time is not useful because it has the low anti-2A, that is thrombin, anti-thrombin activity. Anti-factor 10A is more specific, but not widely available because it can anti-factor 10A assay can be done to check the clotting of the lower anticoagulant effect of the low molecular weight heparin, but it is not widely available. So examples of low molecular weight heparins are enoxaparin, dapiparin, natroparin, dalteparin, pamparin, arteparin. These are the various low molecular weight heparins available nowadays. Enoxaparin, dapiparin, natroparin, dalteparin, pamparin, and arteparin. Now, fondaparinux, what is it? It is the pentasaccharide with specific sequence that binds to antithrombin 3 with high affinity and selectively inactivate the factor 10A. This will bind, it is a pentasaccharide, it will bind to the antithrombin 3 and it will inhibit the factor 10A. So it is the parenteral factor 10A inhibitor. Bioavailability after subcutaneous injection is 100% and longer acting, and it is longer acting. Can't be given in dealer failure. Do not require activated partial thromboplastin time monitoring, longer acting alternative to low molecular weight heparin. This is the longer acting alternative to low molecular weight heparin. It has the less risk of thrombocytopenia and osteoporosis, which was caused by heparin. Shown promise in DVT, that is deep vein thrombosis prevention during orthopedic procedures. Under trial for the ischemic heart disease. The next is the heparin antagonist, that is protamine sulfate, which is strongly basic, low molecular weight protein obtained from the sperm of a certain fish. And it is given intravenously. It neutralizes the heparin weight for weight. This is 1 milligram is needed for every 1000 unit of heparin. Means 1 milligram will be sufficient of the protamine sulfate to neutralize 1000 of the heparin, and it neutralizes the heparin. Used when heparin action needs to be terminated rapidly. It is used when heparin action needed to be terminated rapidly. In the absence of heparin, protamine itself acts as a weak anticoagulant. Means when we do not give the heparin and we just give the protamine, it will act as a weak anticoagulant by interacting with platelets and fibrinogen. By interacting with platelets and fibrinogen, it is acting as the weak anticoagulant. Means it will cause the platelet, it will break down the platelet aggregation, and it will lead to conversion of the fibrinogen into the fibrin. So parenteral direct thrombin inhibitors. First, I have done with you the fondaparinux, which was parenteral 10A inhibitor. The parenteral direct thrombin inhibitors, these bind catalytically these directly bind to catalytic site and substrate binding site of thrombin. This will directly bind to the catalytic site and substrate binding site of the thrombin to inhibit it action independent of antithrombin 3. This is not action is not dependent on antithrombin 3. It will bind to the catalytic site also and substrate binding site also of the thrombin, and it will inhibit it. The parenteral direct thrombin inhibitor is heridin, which is obtained from leech saliva, now available as recombinant form, that is lipidotine. Little action on the platelet. Repeated administration causes prolonged anticoagulant effect. As it produces the prolonged anticoagulant effect, it gives the parenteral direct thrombin inhibitor repeatedly. And FDA approved for heparin-induced thrombocytopenia. Means it's FDA approved to decrease the heparin-induced thrombocytopenia. Cautious use in renal failure. We have to use it cautiously in the renal failure. Bivalirudine is the other uh, parental direct thrombin inhibitor, which is synthetic small peptide, and same as lepidine, it has the action and slowly reversible. And FDA approved it for percutaneous coronary angioplasty. Valerian is approved for percutaneous coronary angioplasty. Argotaban is another parental direct thrombin inhibitor, which is a synthetic non-peptide binds only to catalytic site. It is a synthetic non-peptide. It only binds to the catalytic site. Rapid and short-lasting action. It has a rapid and short-lasting action. Heparin-induced thrombocytopenia with or without thrombosis. Coronary angioplasty. This can be given in heparin-induced thrombocytopenia with or without thrombosis and coronary angioplasty, and it is cautiously used in the liver disease. Thank you. That's all. That was all for the parenteral anticoagulants. I hope you understood this video. And if you understood this video, and if it is helpful and it is useful to you, kindly subscribe to my YouTube channel. That is Dr. Nitika Pharmacology Discussion. Thank you. Be happy, be blessed. Stay safe. Happy learning. All the very best. Thank you.